Hello everybody, my name is Jeff Antone and I am a dosimetrist here in the Department of Radiation Medicine at Northwell Health in Long Island, New York. Today I'm going to be going over lung Imrt and Sbrt overview on treatment planning tips and tricks that we can use in the clinic. Before we get into treatment planning, it is important to set up the patient properly and safely during the CT simulation process. For lung tumors, aids are used to help immobilize the patient. In this image here, a compression plate or a compression belt helps aid in reducing the tumor movement during respiration, thus reducing the margins to account and a reduction in the organs at risk being treated. It is also important to set an isocenter during simulation. This can help further downstream. Minimizing any shifts during the planning process can prevent further errors. 4D CT uses a new technology that captures the location and movement of the target volume and the movement of your body's organs over time. This is valuable for accurately treating the target on or near organs that move, such as those in the chest and abdomen. The information from the 4D CT scan allows treatment planners to design more precise treatments for the moving volumes. We can deliver radiation within a certain interval of the breathing cycle and reduce the risk of treatment-related side effects. After acquiring the 4D CT images, you can use other series rather than the free breathing cycle. The MIP, which is the maximum intensity projection image, shows the most hyperdense value during each pixel data acquired, while conversely, the MINIP, which is the minimum intensity projection images, shows the lowest data value. Average intensity projection takes the average values within these datasets. It is good practice to use each series to help distinguish areas not caught in the free breathing scan. The International Commission on Radiation Units and Measurements, ICRU 50 and 62, help define the GTV, CTV, and PTV when planning. The GTV is the gross tumor volume, which is the gross palpable or visible disease. The CTV is the clinical target volume, which takes into account the GTV plus any submicroscopic disease. The planning target volume is the fudge factor that takes all into consideration the variations when treating the patient on the table. To break that down even further, you have the internal margin, which is the margin added to the CTV to compensate for any movements. Variation in size can occur during breathing and digestion. And then along that is the ITV, which is the CTV plus the internal margin. Furthermore, within the planning target volume that takes into effect all the variations, you have what's called setup margin, which accounts for all the uncertainties, the treated volume, and the irradiated volume. As you can see here, the amount of movement of the target during the breathing cycle. I'll play a video of the 4D cycle being scanned. You can see that the white volume here on the right is going in and out of the PTV margin that was generated. So additional margin might be included to account for the movement sup to inf. Here's a percent depth dose curve, and it shows the interactions as you travel through a medium. You have a buildup factor because there isn't much interaction at the surface, but as you progress, more interactions occurs and dose is deposited, which would eventually reach a dose maximum. But then you'll start to decrease because you're attenuating through more volume, and the inverse square law takes into effect. Factors to consider is ideally we would like to be a whole block of water. However, we are not homogeneous and radiation will react differently. We have bone, fat, tissue, muscles, and sometimes artifacts that affect how radiation behaves. From these tissue inhomogeneities, there are changes in the absorption of the primary beam. As for lung, the density is about 1/3 to 1/4 of that of soft tissue. Due to that, you have loss of electronic equilibrium close to the boundaries of the low density materials or air cavities. When you start using higher energies, the beam has more penumbra. The periphery of the target may be underdosed due to the greater buildup, and is especially seen with smaller field sizes. Here, you can see within tissue, there is loss of dose on the tissue-lung interface. This is a result of a loss of backscatter. Within the lung, dose is initially depressed, but will build up to exceed dose in the homogeneous medium. Then the excess dose decreases because of primary attenuation of the beam. Penumbra within the lung will be greater because of the increased electron range. Here are some tricks to compensate for treatment planners. You can either A, Boolean the overlapping lung and PTV, or B, add additional margins. I will go over how to optimize and what are the effects of using these techniques. You also want to determine the beam angles that will help minimize dose to the organs at risk. Rotating the gantry, you can see in the beam's eye view how much more is involved. The picture on the right shows a little bit more heart in the field, while the picture on the left with rotating the gantry, there's less heart being treated. Rings or shells during the treatment planning process can help tighten your isodose lines. Here in this example, on the contouring module, the ring diagram has been selected to show a 2 cm outer wall margin, followed by 2 cm inner margin that is created to have a buffer between the target and the ring itself. This again aids in tightening the lower isodose lines. During the optimization portion of Eclipse treatment planning, you can decide if you wanted to use the normal tissue tolerance. Under the normal tissue tolerance, or NTO, it will act like a ring structure as opposed to contouring it, and you can decide where you want the dose to start falling off and how sharp you want the fall off to be within a certain distance. You also decide and prioritize which is more important, the fall off to the OARs or target coverage with your PTVs. Some of the tricks during optimization is utilizing the structures you had created during contouring mode. You could either optimize to the expanded volume, and here in the first image was about a millimeter, 3 millimeter expansion, or you can over optimize with the PTV volume that was already created, or the third option is to prioritize the overlapping region in air. There are pros and cons using multiple fields during lung IMRT planning. Having more fields can increase the conformality, reduce hotspots. However, there can be added time for the patient to be on the table should you use static IMRT beams. This can be mitigated if you are using rapid arc planning. One thing to note, if you were to use multiple fields, there is a chance for increased dose to other organs at risk, such as lung, heart, and spinal cord. In this example here, even though it is less conformal to the image of the left, you're preventing low dose spillage into the right lung, while the image on the right, while more conformal, has more lower dose, as you can see with the 80% and 30% into the right lung. Typical constraints that we use in our clinic, we take from Quantex values, and the V20, which is defined as the volume getting 20 gray, should receive less than 30 to 35% of the lung volume, or the lung mean dose is between 20 to 23 gray. Also, with the heart, you want to watch where the mean dose is of 26 gray and the V30 less than 46. Here are some of the effects with alveolar, heart, and esophagus, typically seen within a few weeks of radiation treatment. And also this slide shows the early and late complications with the organs at risk during treatment planning process. Now, for Sbrt, aka stereotactic ablative body radiation therapy, uses smaller amounts of fractions, however, greater dose per fractions. You're getting a big bang for your buck. However, you want to keep tighter margins and setup is more critical compared to conventional planning where you have longer fractionation schemes. You can see standard, it could be 5 days a week where you can have a range from 25 to 35 fractions, while SBRT can probably take even only a day. Here is a beam dose profile. If the beam target margin is close to the penumbra region, around 5 millimeters or greater, we'll typically see this for more conventional treatment. You can get a more homogeneous PTV dose coverage, and the dose maximum will be around less than 110%. You're going to have a slower fall off. But with SBRT, you're utilizing that the PTV is within the beam penumbra, and it's going to result in a more inhomogeneous PTV dose. You want the dose fall off to be much faster outside the PTV, which results in dose greater than 120%. The goal again is here to spare more of the organs at risk. It's important to have proper isocenter setup and patient positioning for SBRT planning. The smaller margins used can result in harmful effects if the patient is not properly positioned or aligned. During the planning process, you might reach a point where you're having trouble achieving PTV coverage or organs at risk dose tolerances, and you rerun through the optimization, and this can lead to over-optimization. What happens is when you're trying to squeeze in that dose or trying to minimize that hotspot for a few slices, it can build up the MUs and it can overmodulate, and one, the patient can be longer on the treatment floor, and two, you can have errors when you're rerunning the dose in QA mode. Looking at the priorities, you can see that they reran it a few times, and now it's harder to decipher which one has more of an effect. Try to keep your numbers simple and make it easier to monitor if you need to go back. Certain things to view during optimization and evaluation is you can look at the conformity index or even the dose gradient index, where you can see how much of the volume is being treated within the target and the fall off to show how steep the gradient is. Again, the goal of SBRT planning is to ablate the tissues within the PTV volume, and these tissues are not considered for risk for complications. And it's okay to have much greater hotspots because the goal here again is to achieve steeper fall off within the organs at risk. In this slide, we have conventional versus SBRT dose distribution. The image on the right shows a higher conformality and rapid fall off in respect to organs at risk, such as the lung and spinal cord. While the image on the left, when considering a lower dose per fraction, it is a little bit more forgiving, even though you're having a little more doses deposited to organs at risk in this lung. Here we have an example of deciding which plan to be used, and we evaluate with a physicist and oncologist. They almost look identical to one another. However, you can see the one on the right is a bit tighter, and evaluating the conformity index, it is closer to 1. You would like to be at 1. Anything over shows that you're treating more than the target volume, and you also want the gradient measure to be lower so you can show the steep fall off. So utilizing their tools, you can see that the one on the right is much tighter compared to the one on the left, and you can also evaluate the lower isodose lines of the orange, which is 25 gray, and the lavender, which is 15 gray, respectively. Here are some of the dose constraints that we've gotten from Timmerman, where you can see the effects of using 1 fraction, 3 fractions, 5 fractions. Again, thank you for taking the time to listen to my slideshow presentation. I hope it was helpful and informative. Have a wonderful time during your treatment planning process. Take care.